Botany? Yeah, botany. And so you're just describing something like, I have a case report of this person doing this, etc. Okay? In an analytical study, you're usually doing some sort of comparison, right? So you can have an observational study where you're not doing a particular intervention, and those can be case control or cohort studies. And you can have an experimental study where you are doing some sort of intervention. You're doing something to make something different. Does that make sense between the two groups? So, and they're randomized and non-randomized. All right. So cross-sectional studies are just a sliver. So like if you think of a giant block of cheese, if you take just like one little slice of cheese from the middle, that's a cross-sectional study. It's just like what happened at that moment in time, right? A retrospective study is backward looking. A prospective study is forward looking, right? So you can have a retrospective cohort, like I look back at people from 2000 to 2015. You can have a prospective cohort of, well, I started looking in 2010 and I finished looking in 2015 and now I have this article. Does that make sense, the difference? Good, okay. And then there are different kinds of studies. So you have the case reports that we talked about, that's just one single person you had something weird happen to and you wanted everybody to know about it. You have case series, which are several different case reports put together. You have case control studies, and these are all observational studies. And then you have cohort studies. There's something called quasi-experimental studies, like natural experiments, for instance. And then there are randomized controlled studies. Those are experimental studies. And then you have studies that pool all of those studies together and tell you kind of the gist of what has been going on. If there's a lot of heterogeneity between the studies, like this person studied it this way and this person studied it a completely different way, and that you can't compare those two because they're studied in such different ways. A systematic review is all you can really do, basically telling you about like, this person did it this way and that person did it that way. But if you can pool the studies because they were done in a similar enough way, then you can do what's called a meta-analysis, and that's considered kind of like the top level of evidence. So randomized controlled studies are thought of as an improved level of evidence over cohort studies because there you're balancing measured as well as unmeasured confounders. So in cohort studies, you can only adjust for the things that you measured, right? But there might be something else that is causing whatever it is that you're looking for to be different between the two groups. All right, so for far better an approximate answer to the right question, which is often vague, than the exact answer to the wrong question, which can always be made precise. So John Tukey is a statistician. He came up with a whole bunch of stuff, actually. So one of the first things that you want to ask about a study is this study asking a testable and meaningful question that they're looking at? So is it testable, right? So like some things are very nebulous. And then, so to be testable, it has to be specific enough, right? And then meaningful, like, is it gonna matter in clinical practice or in further experimentation? And I want to caution you about studies that answer different questions than it actually asks. So I've run across this a couple of times, and that's always just like a huge red siren when I see it, of not the best. Okay, so a good question has to be precise, nothing wishy-washy, measurable, otherwise it's philosophy more than science, concise, so that people can understand you, you're not taking 5 pages to explain what you're doing, relevant, so what is the clinical problem that this pertains to, and impactful, so like you want to make a difference, right? So like I said, methods are really the heart of the paper. One of the things that you want to look at is the population. Who are they testing? Does this apply to the people that you treat? why or why not, right? So if they have a very narrow set of people that they're testing because their exclusion criteria are so lengthy, then this might apply to 2 people in your whole clinic population, right? So you want to look at the inclusion criteria and the exclusion criteria to see how generalizable is this to the things that you do. And then we're going to talk a little bit more about explanatory versus pragmatic on the next slide. So what's the difference here? It's really a continuum. It's not one or the other. But the big difference is that for explanatory studies, you're asking, can this thing work? Whereas for pragmatic studies, you're saying, okay, does it work in a usual clinical practice? So in explanatory study, this is called efficacy, whereas it's called effectiveness in pragmatic studies. So the explanatory studies, you have like the best circumstances. You have people calling you every week, reminding you to take your medicine, et cetera, right? That's not what's going to happen in the real world. Pragmatic is much closer to the real world, okay? And why do we do this? For the explanatory studies, it's to assess like the cause and effect of whatever intervention that you're doing. Does this work, right? And for the pragmatic, it's to inform decision makers like, yes, we should implement this across our whole medical system. This is a good thing to do. This is going to make a difference, right? And so because of the different goals, they have different populations and different methods. So you want to minimize variation, so a very rigid protocol, a very selective inclusion and exclusion criteria to get a very narrow group of people in an explanatory study, and just tons of data collection in an explanatory study. You want to look at all sorts of different things. And then in a pragmatic study, you want to maximize generalizability. So it's more close to usual care. You usually have a very broad inclusion criteria to reflect what a usual practice would be treating. And then your data collection is relatively narrow to the question at hand. So for instance, if we were to look at CBT for insomnia treatment, right? For an explanatory study, you might have somebody who comes every week for 10 weeks and they have very specific, no psychiatric comorbidities, no cardiac comorbidities, et cetera, and you might collect data on all sorts of things, including not just, like your, ISI score, but also all sorts of other measures like your sleepiness, your Pittsburgh sleep quality, and your blood pressure, your sugar control, like just all sorts of things that it might be related to that, right? For the pragmatic study of CBT, you would train some people and then you would let them out into the world more or less for a broad exclusion, anybody who has insomnia, basically, right? Who doesn't have psychosis. And for data collection, you would really focus on the core measure of that thing. So maybe like the ISI, for instance. So they have to be clinically relevant, right? Did you get better? So one of the things that you want to look at is, what is the outcome? When you look at more pragmatic outcomes, they are hard endpoint. They tend to be more hard endpoints, things that are clinically relevant in a very direct way. So like mortality, hospitalization. For sleep, it's a little bit softer of an endpoint because a lot of our things are perception based, right? So like how sleepy you are, I can't tell you how sleepy you are. You have to tell me how sleepy you are. But we do have scales that are validated for that kind of thing. Secondary endpoints are kind of like in the middle. So like cholesterol is a secondary endpoint for cardiovascular risk, right? So primary endpoint would be like cardiovascular death or a cardiovascular event. And the secondary endpoint would be cholesterol. If you change the cholesterol, there is so we have a good theory for why changing the cholesterol would change the endpoint, the hard endpoint of cardiovascular events, but it's not necessarily true, right? So it's possible that you change the secondary endpoint and nothing happens to the primary endpoint. So that's why you have to be a little bit cautious. you want to look at what is the intervention or exposure that they are looking at, okay? Other things to really pay attention to is this an intention to treat or a per protocol analysis? So a per protocol analysis means we only took the people who completed all of our procedures and we looked at only them. Anybody who dropped out, anybody who switched treatments to the other arm because of XYZ are not included in that. The standard is to do intention to treat analyses. Per protocol analyses are very much in the explanatory mold, but even when you are doing that, intention to treat is seen as better because it accounts for instance, like if you had an adverse event from one thing, you might be switching to another arm. And that's, you shouldn't be kicking those people out of the analysis because of that. And then the other thing that you want to look at is what are the covariates that they looked at? What are the other variables? All right. So bias is super important. It's basically the systematic weighing of the scales to get a particular results. And that means everybody gets less accurate results because we're all off. So the first little cartoon is, ever since you told me about confirmation bias, I'm seeing it everywhere. And then the second guy says, you're confirming confirmation bias. That's exactly how confirmation bias works. And then the second one is reporting bias. We won't be needing that sample, and he's throwing the sample into the trash can. All right. So randomized controlled trials are really the coin of the realm because randomization is magic. Like we talked about, it balances both measured and unmeasured confounders. Allocation concealment is even more important than randomization, actually, which means that like people don't know what where the next person is going to be placed in, which group they're going to go into. Blinding, you can have different kinds of blinding. So you can blind the participant, they don't know what they're getting. You can blind the therapist or the person administering the intervention. And you can blind the assessor adjudicator measuring the outcome. And in addition to that, you can blind the statistician. So the most robust studies will blind all of these people. Selection bias, so that just means that people between intervention and controls differ in meaningful ways. And this, we usually think about sampling bias. So basically a non-random sampling of the population. So for instance, pre-screening of participants so that they are not reflective of what your real clinic looks like. Advertising to specific groups, right? People in the hospital versus those in the community. Or, and this happens all the time with research studies, the healthy user bias, where the study population is actually healthier than the general population, because if they're as sick as the general population, there would be some people who would be pretty ill and would not potentially be able to participate in all of the activities of the studies. Participation bias is a really big problem. So like who is the person who's going to sign up for your study? So this is an old New England Journal of Medicine graphic, but it basically looks through, okay, of 1,000 people in the population, let's say 800 report symptoms, then 330 consider seeking medical care, and 217 actually visit the physician's office. So that's your population of interest, the 217 that are going to go to your office, okay? And then, let's see, less than one will be like, so you're kind of looking at the level of severity, right? So you're going down from people who are completely healthy to people who look at a physician's office or a complementary or alternative medical provider or a hospital outpatient clinic or home healthcare, and then emergency department, and how many are hospitalized. And your research population is kind of akin to that less than one that is hospitalized in an academic medical center. So they're people who visit an academic medical center that are motivated enough to participate in research. And there can be issues also with intervention administration. The particular thing is if participants figure out which group they're in, and this is most notorious in the HIV studies, of ACT, where people would actually get their pills tested to see if they were in the control or the intervention group. And that messes up the study because if you like quit the study because you know you're in the control group, like clearly that's not what you're looking for as a researcher. That doesn't give you a good comparison group. All right. Then we talked already about crossover, and the problem with crossover is that it disrupts randomization and you have loss of statistical power. So you underestimate the true effect of the intervention. All right. Attrition bias is a huge thing. So you might have people who sign up for your experiment, but if you have, let's say, multiple sessions, they might come to the first one, but then they might drop off, right? Drop out of one arm. And so there might be systematic differences between those that leave and those that stay, particularly if they're leaving because of, for instance, side effects or the hassle of doing the thing. And so it's important to know that. And it's a serious concern if the loss is over 15%. So hypothesis testing, oft used, seldom useful. So basically, your null hypothesis is kind of like saying nothing to see here. Your alternative hypothesis is like, yes, we were right. Like our hypothesis, something is happening here. All right. And you have two different kinds of error. You have type 1 error, where you reduce, so you basically have a false positive. You say like, you know what, the hypothesis is true, is what you say, but it's not really true. And that often happens in smaller trials because you have a higher chance of type 1 error in smaller trials. Type 2 error is where you have a false negative. You say nothing to see here when there actually is something to see here, and you might be underpowered to see it. Also, smaller trials. So what you're looking for when you look at p less than 0.05, which is, that is a number that we picked that is not picked for a particular reason. What you're looking for is, where do you say that like, this is likely not to be secondary to chance 95%, you know, of the time. All right. So if you look at these two populations and you look at their overlap, you can see where you reject the null hypothesis. That's where you say, okay, my alternative hypothesis is true, is the red. And where you retain the null hypothesis is the yellow. Okay. And alpha is your ability to say, okay, there's probably something going on here. And beta is your power, basically. Is related to your power. Like we talked about, it's really an arbitrary cutoff. So for instance, in genomics, there is a different cutoff. But this is kind of the thing that we've settled on, is I guess the best way of putting it. All right. So as far as p-values and confidence intervals, I would recommend that you use confidence intervals whenever you can and avoid p-values as much as possible, because p-values are actually quite difficult to interpret. And the way that you have to say what your result is according to the p-value is quite strange and difficult and very specific. So the p-values will tell you like, is this different or not? But it doesn't tell you at all about like, is it clinically meaningful, right? So like, for instance, if I have a change in my blood pressure of 1 millimeters of mercury, like that might be statistically different, but I don't care. Like that's not gonna make a difference to me, right? So you see in A, that one is not statistically significant and it's not clinically relevant, right? And B, it's both statistically significant and clinically relevant. Oops, sorry, guys. And the 0 is where you have no statistical difference, basically. So if anything crosses that 0 line in this particular example, it has no statistical significance. And this R, this little R, is the relevance limit. When is something meaningful, right? So like if somebody drops their Epworth from 18 to 12, that's a big deal, right? So that's kind of what we're asking about. So this one is past the little r, and it's past the 0, right? So it's statistically significant and clinically relevant. Whereas this is statistically significant, but not clinically relevant because it doesn't pass this little r. And D is clinically relevant, but not statistically significant because it passes this R, right? But it also encompasses this 0. Right. A confounder is basically a variable that will mess up your experiment because it influences, it's associated with your exposure, with that being the consequence of the exposures. It's not in the direct common pathway, and it's also associated with the outcome, independent of the exposure. So it's not an intermediary, all right? I wanted to give you guys, I think, oh, I had lots of stuff. So I wanted to give you guys some ideas of what this is. Okay, so if you're looking at smoking and the risk for lung cancer, you want to account for age, right? Because age might be related to smoking. Older people are more likely to smoke, right? And lung cancer, like as you get older, you're more likely to get lung cancer, right? So age would be a confounder if you're looking at smoking, relationship to lung cancer. If you're looking at coffee, its effect on pancreatic cancer, you want to account for smoking because perhaps the people who like gulp down gallons of coffee are also more likely to be smokers, and smokers are more likely to have pancreatic cancer. So in order to look at that association, you have to account for smoking. All right. So smoking is the confounder there. So this is one that is really important to point out. So let's say you're looking at the BRCA gene and breast cancer. And we know that the BRCA gene is somehow related to breast cancer. And age is related to breast cancer. So should you adjust for age? Is age a confounder? No, because age has no relationship to your BRCA gene status, right? So you have to have a relationship between the potential confounder and your exposure in order to have it be a confounder. So this just talks about what is the difference between a cohort study and a case control study. So cohort study, whether retrospective or prospective, is forward looking. So you get your sample and then you follow them forward in time and you look at, do they develop this illness or not, okay? So even a retrospective cohort study, what you do is you get your sample in 2000, let's say, and you follow them forward to 2015 to see if they develop the disease, okay? So that's a retrospective cohort. If today I looked at people from 2010 and saw if they developed whatever condition. A case control is retrospective. So you take your population, okay? So people who do and do not have some illness, and then you look backwards and see, were they exposed or not in the past? All right. And I wanted to talk a little bit about St. Z-scores. So in a population, when you have an observational study, you have a lot of varying characteristics, and the characteristics of the two groups might not be the same. So for instance, if you're looking at people who have insomnia, for instance, the people who have insomnia are more likely to have psychiatric comorbidity than the people who do not have insomnia, right? So you want to pick a study group that is matched well to your, to the treatment, to the intervention that you're doing, or to the exposure that you're looking at, on multiple domains. So you have all of these different things that influence insomnia, and you want to make sure that these guys are as well matched as possible on those factors. All right, so that's why here, like, you might have people who have psychiatric comorbidity, who have like high stress in their life, right? So that this might be the insomnia group, let's say, and this is the healthy group without insomnia. And so they might be like more exercising and more, healthy eating and, I don't know, less homelessness. All right. I'm not going to go through this in length because this this is a topic in and of itself. But just to know that there are a couple of different types of machine learning. There is unsupervised learning, where we're basically trying to find groups. We don't know what the answer is, and we're trying to group people. Okay, so this is kind of like saying, when you think about adherence to positive airway pressure therapy, are there different groups of people as far as adherence goes? So like, are there some people who are early starters and then they quit, and some people who are like awesome all the way across, and some people who never even try on the machine? Okay, so you don't know the answer, and you're looking to group people. All right. The supervised learning, all supervised learning, you know the answer. Okay, and it's basically, you either have classification, you're putting people into groups, or regression, something where it's a little difficult to describe. So classification is putting people into groups. Regression can be like if you have a continuous thing that you're measuring. For instance, like if you measure percent adherence from our last example, right? And then there's lots of talk about neural networks, and they make it sound really fancy, but it's not as fancy as it sounds. So basically you have your inputs, which are your variables, right? All of the variables that you have. And then you have a hidden layer. And what you're doing is you're trying to find the weights between the various variables. And then that hidden layer interacts with your output, what's called your output layer, which is kind of like, what is the answer? That's like the layer that's figuring out what's the answer. And then you get your answer. Now this is generally done as a supervised learning, which means you have the answer and you can compare it back and say like, yes, you did this correctly, or no, you did not do this correctly. All right. Okay, so we're on to results. So when you look at results, table 1 is pretty important because observational studies, because what you're looking at is, are the baseline characteristics comparable? And then you're looking at the outcome. Is this outcome about as likely in your practice? So I've seen studies where like they have just wildly different outcomes from me. So for instance, I'm a pulmonologist, so I look at a lot of ICU studies, and in some of the ARDS studies, you know, the mortality is like 20%, and in some of them it's like 40%. That's a big difference. So you have to kind of adjust your expectations based on how prevalent is the outcome. And then there's always primary results and secondary results. So primary results are the thing that you're looking at the most, okay? And that's the thing that this study is like really meant to examine. Your secondary results you can think of as hypothesis generating, but nothing more, okay? They're tantalizing tidbits that you need to do more studies about, basically. The discussion is really nice because it kind of condenses the results in the first paragraph, and then it tries to put it in context for you. So it'll talk about other studies that are related, or past things that have been done that might explain this. And then at the end, usually the last couple of paragraphs, the paragraph before the last one is the limitations paragraph. Like, what are the things that this study did that might not make it representative? And then you want to think about, well, are there other things that they didn't mention that make me not trust the study, right? So like, for instance, if they cherry picked from this particular subspecialty clinic, right, this very particular group of people, those are all limitations to generalizability, right? And the very last paragraph is usually the conclusions. So the order that I read an article is actually the title, and that just tells me like, am I interested in even reading this? I read the author conflicts of interest. I glance through those. Those are pretty fast to glance through. And that just tells me like, okay, like, should I take a more like kind of jaded eye to this or not? Because if it's done by a pharmaceutical company about that particular pharmaceutical medication, then you might want to take 2 looks at those results. Is kind of the way that I'll put it. I'll skim the introduction just kind of to figure out like what's this all about, and then the last paragraph is really the money of the introduction because it tells you what the hypothesis, and that's usually the last sentence of the last paragraph of the introduction. The methods are the real heart of this whole operation, and that's the approach, and that's where you figure out like, okay, is their stuff similar to my stuff? Can I apply their stuff to my population? And then in the results, the figures and tables are your friends. Most of the important information should be in the figures and tables. And the words there are just to basically restate the things that are in the figures and tables. So if you look at the figures and tables, you're usually pretty good. Discussion is really great for context. So putting it into the whole panoply of what we have within sleep medicine. And thinking about meaning. Do you agree with the conclusions of the study, what it means for your population? So one more for good measure. So becoming competent takes a long time. So like that's the X part of this whole slope of how good you are at it. And then becoming marginally better would make you extraordinary. So, and the words are incremental as you're becoming competent, and then exponential as you're becoming extraordinary. All right. So thank you so much. Appreciate that. And any questions? Let's see. I'm going to stop screen sharing and try to go to the chat.
So we got the new fellows on there. That last slide was important because you're in that flat part where you say, am I doing anything? And what's going to happen over the next few months is that you're going to be assigned. You're going to pick papers yourself that you're going to assign yourself to review in detail with one of the faculty people. Write it up and then publish it for our group. So I think, that's what we expect to happen. That a few of them are, they're going to be there. It's going to be a struggle, but then it'll get easier and easier. This was pretty comprehensive, and everyone has different ways of doing it. But part of knowing how to learn 2-3 years from now is going to be dependent on on how you read and how you talk and how you consider new information. So that's my polemic for this morning.
I think what I would say is that you'll come up with your own way of reading this exactly. So like your way doesn't have to be my way, but it's important to have a way.
Yeah. Moshe, what do you think of that? Because you've seen a few of these. Do you do this? Did you do this in pediatric pulmonary?
Yeah, we do. We have sort of the CRISP course, which we take, which is sort of this lecture, but in over a number of lectures that sort of flesh it out, and then we have Journal Club every month where you go through an article. The fellows go through the article and present it with a faculty mentor, and then present it as you would not exactly at a scientific meeting, but sort of pretending you're at a scientific meeting. Obviously, the scientific meetings are much more concise and direct, and then you get questioned on those types of things, and a lot of it at the beginning you don't know, and you have to go back and look up the study designs, look up the especially the statistical analysis, because some of them get pretty complicated. But you over the course of for me, it's been over the course of 3 years or so. I went from feeling totally intimidated by, forget the red journal, even the white journal, to being able to feel comfortable that I will be able to, if I spend enough time, present something to a group of experts from the red journal. Red journal is a more basic science journal, which is sort of outside the realm of my expertise. So I think everything that Anna May said in this talk was actually really exceptional, and I think it's I don't think the expectation is to understand it all at once, but to sort of have this as a reference and to keep on looking back at it and reference it as you actually do the work of going through articles.
See, the problem I have in thinking about a one-year fellowship, and the reason I put this earlier, last year we had it later on in the fellowship. Now we have it earlier in, is it's tough because you were in a 3-year program, and probably by the second or third year, you sort of got it. You could be assigned a paper and know what you needed to do to be able to present that to others in an efficient way. But it's hard to do it in a 1-year program. I mean, maybe we should just, it's really hard to do that. So
I think the other thing is, if you go to, we didn't have a sleep meeting this year, but when you go, I think you really see this, and you see the skill that's involved and the value in it. When you go to the scientific meetings and you see someone who will take a paper and present it in 3 paragraphs, and then you go back to look at it and you try it on your own, you say, man, that is really tough. You have to have a really good understanding, and that sort of sets a bar of like, how efficient do I want to become? And so it is 1 year is not a lot, but it's the beginning.
Yeah, that's why I think the sleep meeting at the end is people are ready to go on to other things, so it's hard to. So this is going to be a focus of the next 2 or 3 months.
The Beyond the Blue is really good at giving you very nice summaries and showing you how to summarize an article. So they usually have, they're done by fellows, and what they do is they'll review a couple of different articles on a theme, and they'll summarize them in a very short amount of time.
But we don't do that in sleep.
No, there's nothing like that in sleep that I know of.
We have to do it internally.
Yeah, but Annie, aren't you an editor of a podcast, a Journal Club podcast from ATS with Jane Taylor?
I am.
So you moderate these things on a national scale.
That's correct.
There you go. We need to have that in there, Eric.
Yeah, I think one of the things with the 1-year fellowship is that at the very beginning, it's really important to focus on reading a textbook so that you get the basics, rather than trying to figure out papers that assume that you know the basics.
Yeah, textbook reading is good. It's your only time you're going to be able to do it. Imagine you're in private practice, you're working 55, 60 hours a week, not in fellowship 55, 60 hours a week, but in practice 55, 60 hours a week. And you want to be able to, you got to be efficient in your being able to digest the literature.
I agree and disagree at the same time, because I have to tell you guys that I still look stuff up in the textbooks. I still go searching for stuff, especially when I have tough cases. I go back to the literature.
Yep. Oh, no, it's not. I mean, it was nice the other day when we had an RLS patient on methadone, and I said, well, let's just go to the practice parameters. Let's start to read that and see what they say. That's why I like the ignorance curriculum. That is, what don't I know about a topic? That's me. All right. Anything